Okay, I think we'll go ahead and get things kicked off. First of all, I want to thank everybody for joining us this afternoon for our webinar, The Significance of Air Quality and Wellness, Reduced Facility-Acquired Infections and Staff Callouts, Prospective and Retrospective Studies in Senior Living. We're very fortunate today to have two exceptional speakers, Dr. Catherine C. Warlow and Susan Schlenner. Dr. Warlow is the founder and CEO of LifeAire. She received her doctorate in anatomy and cell physiology from the University of Virginia School of Medicine and completed her postdoctoral fellowship in reproductive physiology and infertility at the University of Pennsylvania School of Medicine. She served as the director of IVF programs for over 20 years, and that work led to the design and development of the LifeAire system's patented air purification technology, which is dramatically improving patient care in hospitals and long-term care facilities nationwide. Dr. Warlow has also authored 60 scientific papers and chapters and served as an invited editor and reviewer for leading textbooks and journals. She also co-authored the book, Clean Room Technology in Art Clinics, The Critical Role of Air Quality. Our other speaker today, Susan Schlenner, was appointed Executive Director of Phoebe Allentown in July 2017. She has over 20 years experience in long-term care. Most recently, she served in an interim capacity as the Executive Director of Allentown campus. She's been with Phoebe since 1993 and has worked in a variety of roles and departments over the 24 years on 2 different campuses. These include dining services, charge nurse, unit manager at the Allentown campus, director of nursing at Phoebe Wyncote, and administrator positions at both Wyncote and Allentown. Susan received her BS in nursing from Cedar Crest College and is a licensed registered nurse and a nursing home administrator. So again, 2 wonderful speakers today. I will now turn it over to Dr. Warlow.
Thank you, Dave, and good afternoon. Before I begin, I too would like to thank all at Leading Age, and in particular each of you, for joining us today, for the opportunity to share with you not only the pearls and take-home messages of years of intensive research specific to the role of infectious airborne pathogens in health and wellness, but also the genesis and impact of a transformational air purification technology, one truly offering a paradigm shift, if you will, in senior living and staff wellness. We're truly honored to also have been selected as a member solution with Leading Age. Together with my colleague, Sue Schlenner, Executive Director of Phoebe Ministries in Allentown, we are also excited to share the results of a recently completed 15-month IRB-approved environmental and clinical study. It is the vision of Phoebe and their leadership team that embraced the study. And it is this vision that will be instrumental in providing new and critical learnings towards the protection and wellness of our seniors in both adult day and residential settings. So I thank you for their vision. And now we're very pleased to be able to share the data of this 15-month study. As part of our discussion today, we want to define the significance of air quality to staff and senior living residents, define the need to remediate airborne pathogens and volatile organic compounds, or VOCs, discuss the environmental and clinical results associated with the complete remediation of these airborne pathogens and VOCs in the study, discuss the results from a second independent clinical study in healthcare, and finally discuss the positive economic metrics associated with the installation of the air purification technology. So as a beginning point, just to provide a foundation, what's often not understood or not well understood is that of the pathogens that cause illness and infections, 69 to 80% are airborne. 69 to 80%. Secondly, greater than 90% of all infectious pathogens that land on the surface come from the air. Now, your conventional HEPA filtration or MERV filtration, as they call it, does not provide complete or adequate remediation. And everyone with whom we're speaking, whether it be in senior living or healthcare, they are implementing very robust and solid infection control and cleaning protocols. But this is still not completely eliminating the issue of healthcare or facility-acquired infections. And finally, is a final point of foundation for our discussion. Air quality is extremely dynamic. It changes within seconds. It changes because of the presence of staff, residents, your SOPs, activities, adding to the viral load. Just as a point of comparison, this table comes from multiple publications. And as we go through this presentation, we're happy to share, all of the peer-reviewed publications that were used to assemble and put together this presentation. In breathing, if someone is infected virally, you're typically shedding 3 to 20 viral RNA copies per minute, allowing the infection of someone, again, within 6 feet, which is where that social distancing comes from, an infection within 50 minutes. However, if you're speaking, singing, or shouting, you can actually infect someone in about 5 minutes. And these viral particles have a much accelerated velocity, as you would think, and can travel up to 15 feet. Coughing, those viral particles can travel up to 50 miles per hour and up to 19 feet. Flushing a toilet, they've shown viral RNA present in fecal material. One flush of the toilet creates a toilet plume of up to 8,000 infectious droplets. And finally, sneezing. And we've put these in order of velocity and how far they can spread. Sneezing, those viral particles can travel up to 200 miles per hour and up to 26 feet. So this is why we say indoor air quality is extremely dynamic, and which drives the necessity for testing during full occupancy, during natural operation. Clinically, the impact of indoor air quality has been well studied. Air quality can impact health and safety relative to respiratory diseases, systemic diseases, cancer, but beyond health and safety, it can impact cognitive function, learning ability, mental well-being, depression, anxiety, and sleep quality. So taking all into consideration, it is critical to comprehensively remediate the air serving our buildings, clinical, and our residential spaces. Now, we've received a number of calls, especially since the beginning of the pandemic, just asking a lot of questions about the different air purification technologies that are available today. And Leading Age asked us just to touch on this. I would describe it as the wild, wild west. There are a number of air filtration technologies that have been published and presented. Many of them say they are 99% effective in 60 minutes. Many of them say they're FDA approved. Many say that they're able to destroy COVID-19. So part of what we wanted to do today is just to empower you to ask questions and empower you to ask for the data, for the studies, et cetera, just to give you added information so that no matter what decision you make the right decision that's truly going to protect you, your staff, your residents. There are a lot of air cleaning test reports, and they can be sometimes difficult to read. So we wanted to touch on that as well. But again, the main point is just empowering yourself with data and third-party facts so that you can empower your own decision. If you look at air purification or air filtration as a whole, there's additive air filtration and subtractive. Additive basically means that byproducts are added to the air as a result of the technology. It also can mean that there are byproducts that are formed. When you think of additive air filtration, you think of ionizers, bipolar ionization or BPI, needlepoint ionization, plasma. You can think of reactive air cleaners, hydrogen peroxide, photocatalytic oxidation, or PCO. And many of this, their time to effectiveness is 30 to 60 minutes in a very defined, well-controlled chamber. Again, there's very limited operational or real-world efficacy testing data. And that's very, very important to look for and to ask for in evaluating any air filtration technologies. Subtractive air filtration is the opposite. It's basically removing or inactivating targeted contaminants from the air when they come in contact with the particular air purification technology. And again, nothing is added, things are only subtracted, and no byproducts should be produced or added to the air. So that's just kind of a simplistic way to describe most air filtration technologies. We've been receiving a lot of questions about in-room units. And depending upon the in-room unit, they often use the air cleaning technologies we just discussed, PCO with UV, plasma, BPI. And a lot of these are only able to process a small volume of air. And often the infectious pathogens have already entered the space via the ductwork in your HVAC system. So it can take from 30 minutes to 5 hours to completely remediate, whether it be COVID-19 or other more common viruses in the space. Relative to UV, we've received a lot of questions. Can I just install a UV lamp within my ductwork? That makes sense. However, not all UV is effective. You really have to carefully evaluate the space that you want to protect and all of the serving HVAC metrics. You want the proper wavelength, intensity, sizing, reflectivity. There are a number of metrics that need to be carefully considered so that you know after application of the UV that the proper kill will be delivered. Many are talking about using HEPA filtration to protect their space. And HEPA works quite well at any viable particles 0.3 microns or greater. It can capture some less than 0.3 microns, but not at 100%. The other concern that we have had with HEPA, or your capture model, if you will, is that the organics, your viable pathogens, your bacteria, your larger viruses, influenza and COVID-19 are quite small, but some of your larger viruses, bacteria, and fungi will be captured on the HEPA filter, but they'll actually continue to grow. Organics only need two things to survive, food and water. So food is often the other organics, or sometimes the matrix of the filter, and water is simply the humidity in the air. So you often will have organics growing, continuing to grow above the space you're trying to protect. And then with air velocity crossing over that filter, sometimes those spores can be reduced in size and pass through the filter media itself. A lot of your smaller viruses will not be 100% captured, as in influenza or SARS-CoV-2, and none of your VOCs will be captured. As an example, and we see this often in our work, this is the ductwork downstream of a HEPA filter. So the HEPA filter was functioning. These are actually Aspergillus spores. Aspergillus initially is quite large and can be adequately captured by HEPA filtration. But if there's any of the tinier spores that are dislodged, which is what happened here, it can actually coat the inside of the ductwork. Now, this ductwork was the air, if we're all looking at this, the air was actually headed towards the clinical space that you're trying to protect, or the residential space that you're trying to protect. And the reason we have concerns about this is because any fungal spores can produce fungal VOCs, which can be extremely toxic to those in the space. So again, what's important is just, we just want to share a few highlights, but really Empower your decision by empowering yourself with data and information. Request efficacy performance data that supports the claims that are made. Request third-party and independent studies. Confirm that there are no byproducts being produced. Murphy's Law, as we say, you can remove 9 infectious components but produce one byproduct that may be equally as harmful to us. And then finally, understand that the studies should be conducted in real-world settings or in operational settings similar to the space you're trying to protect, whether it be your office, your residential, or your clinical setting. So as I said earlier, we are honored to have been selected as a member solution for Leading Age. And some of the key points that they shared with us of what brought us together is really our operational and real world data from peer-reviewed studies demonstrating the effectiveness of the technology. And Sue and I will be sharing that data from a very recently completed 15-month study in senior living. We're extremely excited to share that with you. Another point that brought us together is in designing the LifeAire system, we set the bar very high, and I'll explain that in a bit. We set the bar very high, and we set the bar to kill the anthrax spore. Not because we were concerned, fortunately, with anthrax, but it's the most difficult spore to kill. So if you're able to kill the anthrax spore, you provide a 9-log reduction of all other infectious airborne pathogens with which we are concerned. And this data actually comes from the National Homeland Security Research Center. They tested the kill of the technology against the anthrax spore. Our technology is now proven with over 28 patents, 20 years of research leading to the technology, and we're installed in over 50 leading healthcare networks. What's driven the unique effectiveness of our technology is really underscored by our genesis. Our genesis began in our determination to protect the human embryo during the 5 to 6 day culture outside of the body in vitro fertilization. We learned the significance of low-level airborne pathogens on our ability to deliver a healthy embryo to the patient and our ability to deliver the highest level of patient care possible. So once we learned the significance of airborne pathogens, there was no air purification system commercially available for us to purchase to deliver these metrics we had learned were so critical to our success. And it was really the absence of a commercial solution that led to the genesis of the LifeAire system. And because it was originally designed to protect the human embryo during in vitro fertilization, the design bar was set very, very high, now offering a technological paradigm shift, if you will, in air purification. The design criteria, we wanted to completely eliminate viable and chemical pathogens. So your bacteria, your viruses, your mold, your VOCs, driving these sources of illness and infection to zero. This is an extremely difficult task to achieve. Again, we chose the anthrax spore as our biological target because then that will deliver a 9-log reduction in the other infectious airborne pathogens. Another very important point, we wanted the effectiveness delivered on a single pass. We didn't want the air to go through this system. And again, as you can see, the system replaces several feet of ductwork within your HVAC system downstream of the air handler. We wanted it to purify all outside source air, no matter what was happening outside, as well as all recirculated air to go through the system. What your staff are doing, your residents, your patients, your SOPs, what those are generating. Again, control the very dynamic viral and bacterial loading within the space. But we didn't want the air, whether it be outside source or within the space, to go through the system 5 times, 10 times, 30 times to deliver the metrics we now knew were so critical. We wanted a single pass kill. Whatever entered the system would not exit. That was very, very important to us clinically. However these metrics were achieved, however bacteria, viruses, fungi, and VOCs were completely remediated, there had to be 0 byproducts, no ozone, and no intermediate molecules produced. Again, it's a difficult design parameter, but one that was very important to us. We also wanted the system to deliver 24/7 during live operation so that you wouldn't lose the loss of the space. So during activities, during typical operation, the system would deliver these air metrics. And finally, we're very much an evidence-based technology company. It is extremely important to us to have ongoing clinical trials, to have peer-reviewed publications, and continue to push the technology. Again, if you're able to provide a kill of the anthrax spore, you provide a 9-log kill of the bacteria with which we are more concerned, which are very common in causing illness and infection: MRSA, C. diff, Pseudomonas, Legionella, Aspergillus, TB, staph, strep, Mycobacterium. Again, this is just a short list of some of those that are more infectious in our senior living and healthcare facilities. On the viral side, again, a single pass viral kill. If you're able to provide the anthrax kill, you provide a very robust, greater than 99% kill of your more common infectious viruses. The system continues to have extensive third-party testing. Again, this is very important to us, to have robust and ongoing third-party testing of the air that is delivered from the system. And as I said earlier, we are most fortunate to have a very strong installation base with clinical providers, senior living providers throughout North America, and just starting rest of world in Europe. So now we're excited to present the results of the 15-month study that was conducted with Phoebe Ministries in Allentown. Again, IRB approved. And at this point, I'd like to welcome my colleague, Susan Schlenner, Executive Director of Phoebe Allentown. And Sue, I'll be happy to advance your slides.
Good afternoon, everybody. Thank you for this opportunity today. To give you a little bit of background about Phoebe Ministries, we're a premier nonprofit senior service organization that's located in Eastern Pennsylvania for over the last 118 years. Our headquarters are in Allentown, PA. We have 4 CCRCs, or continuing care retirement communities, based in Lehigh, Berks, Bucks, and Montgomery counties. We also have our own pharmacies at 3 locations in Lehigh, Montgomery, and Lancaster counties. We have 8 affordable housing apartment buildings. We also have our own rehab services. And we have Pathstones by Phoebe, which is continuing care at home model. Slide, please. Phoebe was founded back in 1903 by members of the Reformed Church, now known as the United Church of Christ. We purchased a farmland with a farmhouse and started the Phoebe Deaconess and Old Folks Home. The ministry grew and expanded over the last 118 plus years. And now, as it's called, Phoebe Allentown, we have 240 skilled nursing beds in our healthcare center. We have 55 personal care studio apartments, and we have 88 independent living apartments. Slide, please. So here's a picture of that farmhouse back in 1903. And now this is our large healthcare center in 2021. I'm going to turn it back over to Katie.
Thank you, Sue. And I'll bring it back to you when we get to the results. So our study, I'm sure it's very important to spend a significant amount of time on the front end of any clinical study so that you look at any potential variables that could influence the data. So our hypothesis, our overall hypothesis was fairly straightforward, that comprehensive remediation of the environmental ambient air reduces common sources of illness and improves resident wellness. So as a study overview, the LifeAire system was designed to destroy the DNA and RNA of all bacteria, fungi, and viruses, rendering them completely non-infectious, as well as remediating volatile organic compounds, or VOCs. So this study compares one floor that was completely protected by the LifeAire system's technology to a second floor protected by HEPA filtration. The study was IRB approved. It was 15 months. It was powered at 90%. It was double-blinded to staff and residents. This is very important because you don't want there to be any subtle changes in behavior just as a result of saying that one floor was protected by a new technology versus another. So it was completely double-blinded. And Sue and her team did a phenomenal job at maintaining that. Very important, no clinical or cleaning SOPs were changed during the 15-month study. And finally, as we said, we compared a control floor with HEPA filtration to the study floor with LifeAire remediation. Our primary outcome variable was that of the environmental metrics. We did airborne and surface sampling in 5 areas per floor quarterly. The samples were all analyzed by third-party industrial hygienist laboratories. And what we received, the data that was received were the bacteria, the fungi, and the VOCs identified not only by species, but by concentration in each of the 5 areas per floor. Our secondary outcome variable was that of healthcare or facility-acquired infections. And finally, very critical, all data was analyzed by third-party epidemiologists. Again, just to give you a visual, there were 2 floors, very similar resident etiologies, which I'll share with you. LifeAire, the one floor completely, the entire floor, community areas, dining hall, nursing station, all corridors protected by the LifeAire systems technology versus a floor immediately beneath it protected by HEPA. This is actually an image of the system. They have an all-weather air long-term care 4000 positioned on the roof. And as you can see, the ductwork and then penetrating down into the floor to protect that entire floor. Again, our goal was fairly straightforward, to completely remove and remediate all infectious airborne pathogens responsible for illness in senior living and the adult day setting. Again, the airborne and surface sampling, we used the most aggressive and comprehensive protocols available, and all data was analyzed by third-party industrial hygienist laboratories. Again, there were 5 areas sampled per floor: the corridor, resident room wing, resident room annex, community area, and dining area. There were 11 surfaces sampled. Sue and her clinical team told us which were the most commonly touched surfaces in the senior living setting. And so those were the samples that were swabbed, again, quarterly, per area, per floor. 7 different areas were assessed for airborne, bacterial, and fungal loading. And VOCs were collected in each of 5 areas as well. So it was a very comprehensive, very thorough environmental sampling, airborne and surface. Just to give you an example visually, this is called an Anderson pump sampler, where air is pulled over the Anderson pump. There's a blood agar plate beneath this. The air coats the blood agar plate, and then your bacteria, your fungal colonies grow over a 72-hour period and then are identified by the third-party lab. So this is an example of airborne pathogen analysis or collection, really, in one of the resident rooms, in a resident bathroom, surface swabbing in the restroom, again, on the grab bar, most commonly touched, both airborne and surface sampling or collection in the community room, a second community room, the dining area. Again, you can see the airborne collection here. In another dining room, the cart, the handle on the cart in the dining room, nursing area, hallway corridor. And another point important to know is that during the study, both their PTAC units, we wanted everything to remain as is and continue to function. The only thing that was changed on the study floor was that of the LifeAire remediation. So all of their PTAC units within the rooms, as well as their unit ventilators at the end of each hallway, were operational and running as they always are. Again, we only wanted to change one variable, and that was LifeAire remediation. Our goal, again, complete removal of all infectious airborne pathogens. The results, when you look at the resident demographics, there were no statistically significant differences between the control floor and the study floor relative to the number of residents per floor, mean age, etiology. These were both memory support floors, percent female, male, race, no statistically significant differences. Very important. When you look at the results, comparing the study floor, the LifeAire protected floor, looking before in the gray versus after installation, you look at viable pathogen loading. These are viable bacteria and fungi within each of those 5 spaces assessed environmentally. And you can see the dramatic decrease from before versus after in each of the 5 spaces. So this is a graph just showing your viable pathogen loading. This is showing your VOC loading before and after in each of the 5 spaces. So there's a significant reduction in both, which was our goal. When you look at the environmental metrics as a whole, there was an 89% reduction in infectious airborne pathogens, which drove a reduction in infectious surface pathogens to 88.9%. Again, 90% of the infectious fomites that land on the surface come from the air. So that when you drive the airborne infectious pathogens down, you're going to significantly drive your surface pathogens down. And what that does is you are removing or reducing, dramatically reducing 2 very common vectors of illness or infection. In addition, there was a 90% reduction in VOCs. So again, removing or dramatically reducing 3 common sources of illness and infection in senior living. As a result of doing that, there was a reduction in facility-acquired infections or healthcare-acquired infections by 39% on the LifeAire protected floor versus the HEPA protected floor. So therefore, our overall goal was improved resident wellness and quality of life. And a metric we actually were not considering in the original protocol was that of staff callouts, which they reported to us a reduction in staff callouts on the floor protected by LifeAire of 47%, which was significant. Looking into the details of the HAIs that were reported and using their reporting structure, these were the common HAIs that were analyzed and reported. If you look at the retrospective data on the control floor, between 2018 and 2019, there were really very few differences on the control floor, which is a good indicator of stability. On the study floor where LifeAire was installed, We had 44 HAIs specific to that area in 2018 and 20 in 2019. So that's a decrease of about 54 percentage points retrospectively. If you look at the prospective data, so in other words, at the same time during the entire course of the study, on the control floor, there were 53 HAIs compared to the LifeAire protected floor of 32. So that's a prospective decrease of 39.6%. And this is the number that we typically refer to. They also shared some of their micro data from the laboratory. In other words, when a resident tested positive for an HAI, which microorganism was responsible for that. So on the control floor, these were some of the more typical microorganisms that contributed to HAIs. And as you can see, anything in the red yes are those that are airborne. None of these were found on the study floor, the LifeAire protected floor. And Sue, I'll be happy to pass it back to you to share the economic impact of the study.
Thank you, Katie. Some of the impacts that we saw through the study were improved resident wellness and statistically significant reduction in health-acquired infections, almost 40%. We also, as a secondary metric, as Katie stated, we weren't officially tracking through the study, but we did see a reduction in staff call-outs of around 47%. We're hoping in the future that we're going to see a reduction in citation for infection control outbreaks or civil monetary penalties. Market differentiation to the community, families, residents, payers, and providers. And hopefully we'll see an increased referrals from our healthcare network providers and insurance companies, improved reimbursement from payers, and a litigation offset decreased by liability and insurance. With increased referrals, as a post-acute provider, we have contracts and agreements with our hospital networks and insurance companies. And staying preferred providers and maintaining that network inclusion is very important as post-acute providers. We are held to metrics such as 30-day readmissions, ER visits, cost of care, amongst many other metrics. Also, CMS also holds us to readmission metrics for reimbursement under the SNF VBP. This program awards SNFs with incentive payments based on the quality of care they provide to Medicare beneficiaries as measured by performance on a measure of hospital readmissions. So it's scored on both improvement and achievement. And depending on your performance on readmissions, you can receive up to an additional 2% of CMS reimbursement, or they can withhold up to 2% of SNF's Medicare fee for service Part A payments. So a facility our size as Phoebe Allentown can affect a large amount of our reimbursement dollars. Next slide, please. So the LifeAire system significantly reduced levels of infection, airborne, and surface pathogens and VOC levels during a live and fully operational senior living residential setting. We also seen a reduction of up to almost 89% retrospectively of surface and airborne pathogens. We also seen the levels of VOCs were reduced by 90%. Airborne and surface pathogens constitute a significant source of illness and infection. VOCs negatively impact residents with compromised respiratory systems, such as COPD. By dramatically reducing 3 common vectors of illness, the residents on the LifeAire protected floor demonstrated statistically significant decrease in health-acquired rates. So these findings support the hypothesis that environmental factors impact resident wellness. So the LifeAire system is currently dedicated to our memory support, and most of you know people with dementia or Alzheimer's disease who fall ill can express their symptoms and may, in early stages, mimic some of their pre-existing behaviors or conditions, and could go undiagnosed until, of course, there's some subtle changes in their medical condition. But often, residents with dementia are also unable to follow infection control practices such as isolation, masking. So I feel we protected one of our most vulnerable populations within our facility. Also, as a post-acute provider, we never proactively looked at indoor air quality before. We think of our own systems as conventional systems with HEPA filters, or even thinking of what we have in our own homes. But the LifeAire system is much more advanced than that. I also feel we're all very excited about the LifeAire system. I believe the best products and technology created respond to serve a solution to solve a problem or prevent a problem from happening. LifeAire technology keeps people safe and healthy. Actually feel, we call it the silent champion here, because 24/7, that system is killing bacteria, viruses, fungus in the air and on the surface. But most of all, we are protecting one of the most vulnerable populations of people, the elderly. By improving air quality, we're also helping our staff. We have almost 400 staff that come to our building every day. So we are not only protecting our residents to the highest quality and promoting highest level patient care and quality of life, but we're also protecting our employees. So LifeAire impacts everyone in our community. And I am very honored to be working closely with the LifeAire team for the last 5 years. And we're going to continue and forge our work together, because we have an opportunity here to impact and improve our industry of post-acute care, and as it relates to indoor air quality and being proactive with that, not reactive. So I'm very honored to be a part of this team and change the future. And hopefully we have impacted some of you today. So I thank you for your time. I'm going to turn it over to Katie.
Thank you, Sue. One final point I wanted to make. I mentioned earlier that there was a second independent study, and I apologize for the Pennsylvania sun here. So it's shifting quite quickly. But we had a second independent study, 12-month study in healthcare. And the metrics were slightly different, but again, the study concluded that the LifeAire protected floor drove infectious airborne pathogens down by actually 98, 99%, as well as a 97% reduction in the infectious surface pathogens. And that also drove their HAIs down. It drove their readmission rates down, and their length of stay was reduced by 39%, which drove a significant cost savings of actually $2.3 million in 12 months, specific to 16 patient rooms. So that was a second study being run completely independently of the study we wanted to present here. But I thought it was important to mention the two different independent studies. And again, as Sue said, just our goal was improved resident wellness, quality of life, and also sending a strong message to the staff as far as their protection as well. So what really began with the goal of protecting the human embryo, because of that goal, again, it set the design bar for the technology extraordinarily high. And because of that, the system has really offered a paradigm shift in complete remediation of infectious airborne pathogens, reduction of surface pathogens, therefore removing very common vectors of illness and driving illness and infection down, driving readmission rates down, length of stay, improving overall wellness and quality of life. So we're really honored to have the technology really impact across a continuum of care. So I thank you for your time and your attention. We're happy to take any questions or follow up with you afterwards. We just showed highlights of the data. We have a very large database that we're happy to talk about with each of you. But Dave, I'll turn it back to you. And thank you again for your time and attention.
Okay, great. Thank you, Katie. Thank you, Sue. That was fantastic and very compelling information. We do have a couple of questions that have come in. We have time for a few of these. So I guess, Katie, this one would be for you. Other technologies show third-party data of 99% effectiveness on COVID. How is your technology different?
I think the main thing is our genesis, where we defined the airborne metrics that were so critical and then designed the technology to deliver those metrics. I think another differentiator, Dave, is delivery of the kill in a single pass. So again, whatever enters the system does not exit, and it certainly does not exit viable. Another differentiator is proven absence of byproducts produced or intermediate molecules or ozone. And again, because we set the bar high because of our genesis, we are providing a kill of anthrax and thus a 9-log kill of all the other infectious airborne pathogens. And finally, the operational data that we have. It's very important to us that the technology be tested again, within the space you're trying to protect, within your senior living residential spaces during live operation, as the residents are there, as they're participating in activities in the community room, as they're dining, as someone is sneezing and coughing, a real world operational setting so that you know that protection is occurring at that time.
Okay, great. And actually there's another question. You touched upon this a little bit, but the question is, why is a single pass kill so important?
Earlier in the discussion, we talked about viral loading and how quickly air quality can change. So the air quality in this room where I'm in right now, I'm the only person in this room. So the air quality is going to be equal to X. Add 3 more people to this space, breathing, talking, sneezing, coughing, and your viral loading obviously goes up, and it can go up within seconds. So what's important with single pass is that the air that enters our system exits without any viable bacteria, viruses, or fungi, or VOCs. Because again, you don't want air to have to go through a technology 5, 10, 20 times to deliver that effectiveness.
Okay, great. I think we have time for one more. The question is, can your system be installed in existing facilities?
Yes, probably half of our installations are existing. The only thing they did as Phoebe Ministries, nothing else was changed. They installed it within an existing building, with their existing HVAC system. So probably half of our installations are what we call retrofits, are within, pre-existing facilities.
Got it. Okay. I think we're out of time here. We do have some other questions. If we didn't get to your question, we will be answering those. But again, I want to thank Dr. Warlow and Susan Schlenner for joining us today and presenting the data on a very robust study. Thank all of you for your time this afternoon. I hope the information was very worthwhile. And as you see on the bottom here, if you have any questions or want some further information, you can reach out to Sue, myself, or Dr. Warlow. So again, thank you all very much and have a great day.
Thank you. Thank you very much and stay safe.
Okay. Bye-bye all.